Good afternoon. My name is Dr. Helen Elliott. I am a senior lecturer at the University of Greenwich, which is in the UK. This study is about public health nurses and their identification of domestic violence and abuse. To give you an overview of what I plan to cover this afternoon, I will give you a little bit of background about me, the rationale for the study, current evidence, the research methodology, and explain the findings, and identify implications for policy, practice, and education. I have a background in public health nursing and currently work as a nurse educator. In the UK, every family with a child under the age of 5 are able to access the support and advice of a public health nurse. Part of the public health nurse's role is to safeguard the children in the family and to identify health needs. Every mother who has contact with a public health nurse are routinely asked about domestic violence and abuse. It is actually a policy in the UK that stipulates that at every contact, as long as it is safe to do so, mothers are asked about domestic abuse. And public health nurses are expected to make a routine inquiry at each client visit. So I wanted to explore more fully how practitioners were actually asking about domestic abuse and if there were any influencing factors that would affect their ability to ask this very challenging question. Also to find out when they made the decision to escalate their concerns, what is it around that client contact that made them think actually now is the time to escalate the concerns and sort of bring in wider services. And the other thing I wanted to find out was whether there was anything in particular in terms of education and training that would support the practitioners in how they actually support women who are suffering from a domestic abuse, or in terms of that routine inquiry, how to ask that question. So there are a number of research studies that have been undertaken around routine inquiry, and those particular studies involve people like the general practitioners, midwives, and public health nurses. However, there was very limited research that was solely focused on public health nurses and routine inquiry, so there was actually a gap in the knowledge. In terms of the methodology, this was a mixed method research study that was undertaken in 2017 within the National Health Service in the UK, and it was focused around a community trust. This was a purposive sample of experienced public health nurses, and the data was collected through surveys and semi-structured interviews. Ethical approval was granted and data was analysed using thematic analysis. The next few slides will focus on the qualitative data using some examples of the public health nurses' feedback to illustrate some of the key points identified. The opportunity to conduct routine inquiry was something that was quite evident, that came out quite clearly in the data. Public health nurses said that they would ask each client about domestic abuse whenever it was safe to do so, so they were very clear about their role. They did feel that they had the right skills to engage with clients who were often at home and often meeting them for the first time. However, the practitioners were careful and mindful to choose the right moment and wouldn't ask about abuse if there was a child over the age of 2 or if there was another adult present. The identification of domestic violence and abuse is not only about evident signs of injury, and the public health nurses were able to talk about how they identified the nonverbal signs that something may be going on, they would often use their intuition or their sixth sense to identify that something may be going on and abuse may be something that is occurring within the relationship. And so when they use their intuition to identify something that they needed to follow up later on, they would then make sure that they made contact with that mother at another date and the partner was not around to have a conversation with her. So they were really mindful that they needed to engage with women from a very early stage of the professional relationship. And so the women would feel more likely to disclose to them if they were concerned about their safety. Public health nurses raised the issue around why women stayed in abusive relationships. They gave some examples of how some women did not have access to their passports or had entered the country illegally and could not leave the abusive relationship. They also identified some cultural and religious reasons as to why some women stayed to avoid bringing shame to the family. The public health nurses called for more training around cultural competency. They identified a lack of understanding around some cultures and how they could best engage women by understanding the culture. The public health practice nurses identified that when women required an interpreter, they were often unsure if the inquiry around domestic violence was being translated correctly. They also raised concerns that often the translators would have been male and make it less likely that the woman would disclose any abuse in the presence of a male interpreter. A few of the public health practice nurses were mindful that an interpreter was coming from the same community as the women and may actually know the family. Therefore, they were less likely or unlikely to actually gain an honest response from the mother when asked about domestic abuse. Another element the practitioners highlighted was about the time constraints that they had. So they had very limited time to actually explore fully if they had concerns about abuse, and sometimes needed more time to go back and even go back again to the family home or see the mother in clinic to try and use every opportunity to encourage a disclosure. Some of the public health practice nurses talked about how they grew up in cultures where domestic abuse and violence occurred within their particular culture and within their particular country. And so they had personal experience of living through within families where there was domestic abuse, while others clearly understood why women might need to stay in a relationship and feel that they had no other choice but to stay in a relationship. The practitioners did sympathise with them, while others were quite clear that professionally they would support the women, but personally they didn't understand why the women would not leave. Some of the public health practice nurses had fears over their own safety. That was something that was quite evident with discussions, particularly when I conducted the interviews. They were often quite frightened about going into a family home to visit a mother with a new baby, particularly if they were aware that domestic abuse was within that relationship but hadn't been disclosed by the mother, but they had a duty to go into the family home to visit them with their new baby. And some of the practitioners actually felt they needed support themselves. Listening to women who do disclose domestic abuse is quite a traumatic event for the woman, but also for the practitioner, who often feels helpless to support and to get them out of that situation, particularly when the woman feels there is nowhere else to go. So the practitioners explained how they often turned to more senior members of their team or they wanted to access counselling but wasn't quite sure how confidential that service was. So they were actually looking for support themselves. And the practitioners were asked about when they would escalate the concern. So when considering there is a child in a family where they suspect domestic abuse is occurring but may not have been disclosed, at what point would they actually escalate their concerns to others? And one of the things that they did say very clearly is that if they had concerns that a child was going to come to significant harm, they would not hesitate to escalate their concerns in order to safeguard the children in that family. An interesting aspect that emerged from the findings is that practitioners felt that the training was sometimes limited. So the education and training that they had had around domestic abuse and asking about and routinely inquiring about abuse, they felt that their training was somewhat limited and didn't address issues around female to male violence. And it was mainly male to female violence that the focus was around. And they didn't feel equipped to deal with situations where a man was being abused by a woman. And they did not ever ask about domestic abuse. They never asked the father. Another area that was actually an interesting finding was around practitioners saying that when they went in to do that first visit, they went into the visit and then found that there was a same-sex relationship. So the parents were in a same-sex relationship, and again, practitioners didn't feel confident in knowing who to ask or how to ask about abuse, and they often didn't ask at all. They just ignored it, even though there were children in the home, because they didn't know how to. So one of the things that practitioners were asking for was regular updates around domestic violence and abuse. They wanted regular updates and practice sessions in how to routinely inquire about abuse. And they often felt that when they did have the training, that improved their practice. So they felt that was really, really important. One of the recommendations, well, a few of the recommendations that I've identified here is around the interpreters, the use of the interpreters and the influence that they could have on a mother's ability to feel that they could actually disclose that they were living in an abusive relationship. So the recommendation would be that we could use more technology, such as smartphones and iPads, in English and also in other languages, so that women could be asked about abuse without having to go through the interpreter, but a message could be sent to the woman via text and they could respond accordingly and feel that they were safe to do so. So the use of technology would be helpful in this situation. And the other thing was around making sure that the practitioners were able to self-care. So they had the tools and the equipment to look after themselves, so they would be able to then continue in the role and taking on the burden and the responsibility of supporting women who some have been through very traumatic relationships. So meditation, yoga, and mindfulness was one of the things, some of the things that that practitioners were asking for. They want to be trained how to do those and other self-care areas, so that they could actually look after themselves. So implications for policy. It should be acknowledged that public health nurses are autonomous practitioners in their own right, and as such, they should be given the responsibility and the ability to carry out their role, but also to allow them to make decisions around how much time is required to spend with families, particularly if they suspect domestic abuse is occurring. So practitioners need more time to reflect around the needs of the clients, and the policy makers need to engage with the practitioners to assess the level of risk and to evaluate and update policies. So here you see from the findings and the recommendations, I've actually identified here a new model. So this is an education and training model that I've actually put together based on the findings from this study. And it's around focusing on the clients, identification, influencing factors and resources. So when you are developing a training package for practitioners, these are some of the elements that should be within that training package in order to develop practitioners to be confident and competent in asking and supporting women and families who are in abusive, that there's abuse within the home environment. Further research that could be undertaken on the back of my research is around intuition and the identification of abuse. There could be more around resilience to prevent burnout, and when particularly supporting clients, how to prevent burnout from the practitioners, and interpreters, something around establishing how interpreters could influence the routine inquiry, and how their values and beliefs may have an impact on how they interpret and routinely interpret questions around domestic abuse. Thank you very much. Do you have any questions?